of her own images, and she's in charge of our web design at our school. So it's another awesome thing she does. All right, our next presenter is Jessica Chen. All right.
Hi everyone, my name is Jessica Chen, and today my presentation is on infectious and HIV-associated complications of immunomodulatory agents in patients living with HIV-1 infection. I know that's kind of a really long title, but we'll break it down later. So a little bit about me in the hemorrhage lab. I will be a rising senior at Lowell High School, and this is my first time officially interning at a lab with my own project, so I was super excited about that. And the hemorrhage lab studies HIV-1 and the characterization of HIV-1 latent reservoirs. So HIV latency is when immune cells are infected with HIV but aren't actively producing new HIV. So a little bit of background information. HIV is a virus that targets the immune system, and it specifically targets helper T cells, so CD4 T lymphocytes, and to a lesser extent macrophages and dendritic cells. And a comorbidity is when a patient has two or more medical conditions occurring simultaneously. ART is antiretroviral treatment, which is used to prevent HIV replication. And biologic immunomodulatory agents are drugs that are comprised of immune system molecules or target-specific receptors that lead to immunologic response against disease. So these are used to treat inflammatory and autoimmune diseases, such as rheumatoid arthritis or psoriasis, as well as cancer. So my research question was, is it safe for patients with HIV and medical comorbidities to use these biologic immunomodulatory agents? So there have been no major studies published regarding the prescription of these agents and their medical outcomes. And medical providers right now usually don't recommend their patients with HIV and medical comorbidities to use these agents due to concerns that this could lead to a loss in HIV suppression from ART. So the materials and methods. We queried the UCSF and DSFG medical records to identify patients between 2000 and 2018 who met our criteria. They were over 18 years of age, they had a positive HIV antigen antibody test, and they were prescribed a biologic immunomodulatory agent. So in total, we identified 76 patients and abstracted the following data. As for HIV history, we found their ART treatment history, their CD4 nadir, which is the lowest CD4 count, and their duration of infection. And for longitudinal data, we found a viral load, CD4% and CD4 to CD8 ratio for all the data points possible. And we found a comorbidity and immunomodulatory medication as well. As for demographics, we found the age, gender, and race. So on this pie chart over here, it shows the immunomodulatory class of agents. So the most commonly used were the TNF inhibitors, which are shown in red, the PD-1 inhibitors in yellow, and the antimetabolites in green. So an overall conclusion we reach is that immunomodulatory therapy is tolerated in patients with HIV and medical comorbidities without major adverse events. So there were no cases of virologic or immunologic failure in all the patients that we studied, but for individuals who experienced viral blips were resuppressed in all cases. And a viral blip is when there are 50 or more copies of a virus per microliter. Next, individuals that initiated therapy while viremic did well, as in individuals with CD4 counts of less than 500 cells per microliter. So this suggests that these agents can be safely administered in monitored settings. Third, there are few infectious complications, none of which were clearly attributable to immunomodulatory therapy. And a really interesting find that we had was that PD-1 inhibitors appear to be associated with an increased level of low-level viral blips. So over here is our table. So there were 76 patients in total, but 109 treatment episodes, because we define a treatment episode as an uninterrupted period on a particular drug regimen. So if patients were on multiple drug regimens throughout their life, they accounted for multiple treatment episodes. And there was a total of 56,735 patient days from which we abstracted data, which is quite a lot. And then on the right side over here, we have a Kaplan-Meier curve. So on the x-axis over here, it says days since immunomodulatory therapy initiation. And on the y-axis, it shows the percentage of patients remaining that had an undetectable viral load. So So as you can see, both of them started at 100%, but every time a patient had a viral blip, the percentage would decrease. So you can see that over time, the percentage of patients using PD-1 inhibitors that were undetectable were much lower than other agents. So kind of as a quick wrap-up, biologic immunomodulatory agents are overall safe for patients with HIV and medical comorbidities, and anti-PD-1 therapy increases the likelihood of low-level intermittent plasmaviremia or blips. So I'd like to give a special thanks to Dr. Michael Peluso, who is the clinical fellow I worked with on this project, Dr. Timothy Henrich, who is my PI over there, thank you for coming, Adria Reed and Sadie Munter and the Henrich Lab. Sadie Munter and Adria Reed were the two undergraduates I worked with as well. The Clinical Data Research Consultation Service here at UCSF, who did the initial queries, and most of all, the UCSF LSRP program, specifically John and Ms. Kilpatrick, for letting me have this opportunity. Thank you so much. Are there any questions? Okay, question.
Talk about the significance of these viral blips and how come, and in terms of these blips, how long are they, and do they like become undetectable after a certain period of time?
I'm not
without any change any changes in treatment regimen that
So I'm not quite sure like the specific period that the viral blip is considered, but it's usually I think within like the next time the patient comes back, and if the viral load it's usually undetectable by then. That would be considered a viral blip. Sorry, did that make sense? So a patient had above 50 copies per microliter, and the next time they came back, it was undetectable. What was the second part of your question?
any significance to that?
The viral blips?
Yeah.
So if there are a lot of viral blips, it shows that the patient is kind of unstable and the ART treatment might not be working as well. And there's a question over here. Oh, okay.
So what are PD-1 inhibitors?
So PD-1 inhibitors, so they bind with PD-L1, and so basically they when there's that binding, it kind of tells other cells that they can kind of like leave it alone. But these PD-1 inhibitors inhibit that binding so that there's no like cancerous growth and stuff like that. Are there any other questions?